The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss neurological complications of brain tumors. My name is Vince Rock, Program Manager here at the American Brain Tumor Association. I am delighted to introduce our speaker today, Amy A. Pruitt, MD. Dr. Amy Pruitt trained in neurology and internal medicine at Harvard Medical School and Massachusetts General Hospital. She is Professor of Neurology and Vice Chair for Education at the University of Pennsylvania in Philadelphia. Her clinical specialties include the management of brain tumors and the diagnosis and treatment of infections and other complications of transplantation and cancer therapies. Thank you for joining us, Dr. Pruitt. You may now begin your presentation.
Thank you, Mr. Rock, and thank you to the American Brain Tumor Association for inviting me to discuss the important topic of brain tumor symptom management. Thank you to all who are joining, and I look forward to answering your questions at the end of the presentation. Patients with brain tumors have many disease and treatment-related problems that really impact their quality of life and actually even overall survival. And these require management from multiple types of doctors and other caregivers. Brain tumor symptom management can be conceived of, as I do, as a spectrum of care, addressing the needs of patients and family members from the diagnosis and active treatment phases on through supportive care or the increasingly important area of management of long-term complications of treatment as more people with brain tumors are living longer due to better therapies. I have a couple of disclosures, or really lack thereof, before I begin my presentation. I have no financial interests in anything I'm about to say. I have preclinical and clinical trial support from Teva Pharmaceuticals for therapies unrelated to brain tumors, and I will be discussing some therapies for such important symptoms as fatigue and cognitive dysfunction that are not FDA approved. That's the Food and Drug Administration for this indication. So as I will emphasize throughout and particularly at the end of the presentation, please be sure to ask your own physicians about their opinions on specific therapies and specific problems. I will begin to address with the entire problem with who is the neuro-oncology team. So neuro-oncology is a specialty that's been around in our purview for about 40 years now. And sometimes we've been joined by a whole host of other physicians that help with symptom management and hopefully coordinate care among many specialists. On my next slide, I'm talking about some of the overviews that we're going to be talking about in the course of this discussion. Who are the members of the neuro-oncology team and what are their goals? The common problems listed in 1 through 7 on the slide that you now see on your screen are the really important things that we will be discussing throughout this particular seminar. I hope we will have time to discuss long-term complications because, as I mentioned, these are going to be increasingly important parts of the long-term survival of patients with these diseases. So here's our team. Right in the center is the patient and the people who really are related to that patient, are good friends of that patient, the people who are the day-to-day and hour-to-hour supporters. I've put the surgeon at the top. I think that's where surgeons like to be in general. The surgeon is certainly a very important part because it is uncommon for someone to have treatment for a brain tumor if he doesn't have a diagnosis of what the problem is. And that may be one of the questions that we'll come to towards the end or in the question and answer session. A medical oncologist may be the person who does the primary administration of chemotherapy, and I would encourage you all to keep your own primary care doctor involved as much as possible. This is a really important person in your care team. He, after all, has known you and possibly other family members for a long time before this particular problem arose, and we try to keep our primary care referring physicians up to date with everything that's going on as we proceed through the treatment. Physical therapists, rehabilitation specialists, palliative care people are all going to be mentioned throughout the course of my presentation. A neurologist may actually be your main doctor. One of the big questions that comes up when you've got so many doctors is, do you really have any one person who is the quarterback, if you will? Sometimes it's the medical oncologist, Sometimes it's the neurologist. Sometimes you have a specialist who is a neuro-oncologist, and that may be the person that you refer to. There may be different doctors for different phases of the treatment. It may be that you return to the care of the first neurologist who made the diagnosis, and that may be the person who follows you for much of the course. You may return to your primary care physician. A different team called the Palliative Care Team, which specializes in the management of symptoms and serious illnesses, may be right alongside your primary team. Over on the left-hand side of the diagram, I have nurses and nurse practitioners. Virtually everyone in our neurosurgical and neuroscience departments works with nurses and nurse practitioners on a day-to-day, hour-to-hour basis. They're incredibly valuable symptom managers and will be communicating with you at least as much sometimes as your primary care doctor or neurologist. Equally important are social service people and psychologists. They can be helpful in symptom management along the way. I'm going to skip right navigators for a second, move down to the bottom, the radiation oncologist. That person may be your primary doctor during the 6 to 8 weeks that you are getting radiation therapy for many of these problems. And down on the bottom are some other important people. Research coordinators, people who will help think through the informed consent process if you're involved in the clinical trial. Pathologists, you may want to go to more than one place, get a second opinion. Is this really the pathology that we're dealing with? A radiologist is incredibly important in the diagnosis and follow-up phases. And a pharmacist is behind the scenes helping make sure that we get the drugs in the quantities we want when we need them, and also helping with some of the financial ends of these often very expensive drugs. I left one very important group out on purpose. That's the navigators. Some of you may have already had the experience of having so many doctors that you don't really know where to turn. And there is a navigator who helps people through these systems. If this is in place, in the place where you're being treated, ask about it. It can be an incredibly important ally in an often very stressful and confusing time. But whatever the number of people on your team, the team has the same goals. We want to choose the best possible treatment for the patient's personal situation. You've heard about personalized medicine, and from the cellular level under the microscope to the way a person wants to deal with these serious illnesses is really a very personal matter. So that may differ from one person to the next with exactly the same kind of problem. We want to improve quality of life during and after treatment. We want to keep people out of the hospital. As you have well learned, that's no place to be when you're not feeling well. You want to be at home as much as possible. And there may be specific needs, specific patient-generated goals that are really important here. So back to the things we're about to talk about. Seizure medications, are they always needed? And is there a best drug? Steroids, almost everyone listening has probably had either himself or someone in his family on steroids, and therefore almost everyone listening has probably experienced some of the side effects of medicines. Blood clots, the big word for that is venous thromboembolism, can be incredibly important, very dangerous, and sometimes fatal in the immediate period around the time of a brain tumor operation. Infections can happen, particularly when people need to stay on steroids for a long period of time. Mood and cognitive issues are, I believe, an under-recognized and underserved area of this whole endeavor, and I'm going to spend some time on what we know about medicines and therapies that can help. Fatigue is a huge problem. It isn't just that you've had major surgery and that you have to trek into the hospital for a few minutes of treatment for 5 days out of 7, 6 weeks in a row. There are lots of other reasons that people get fatigued with these therapies, and one of them is that the steroids really mess up the sleep-wake cycle. Gastrointestinal problems can be huge. There can be stimulating appetite with people having 30-pound weight gains from steroids, or the opposite can happen. People can have nausea that sometimes isn't very well explained, but for which we have better and better therapies. Let's not forget the last two things on the page here, rehabilitation and palliative care. Rehabilitation from the effects of surgery and or the treatments, incredibly important, and having a stay in a good rehabilitation facility can make a world of difference in getting back to your usual activities. Palliative care I will define and spend more time on later. For those of you who are medically oriented, there is a review article listed at the bottom here, and this covers many of these from a medical perspective. So now on to some of the big problems. Tumor-associated swelling or vasogenic edema. What does that mean? It means that the blood vessels, the vaso part, genic, that we do to the blood vessels, there is leakage of a fluid filled with protein out into the area around the tumor. One of the thrusts of research has been to find good drugs that will help us reduce the amount of swelling. I'm showing a picture of a glioblastoma here. It's in the left frontal lobe. So on these pictures, left is right and right is left. So this is the left frontal lobe. And this darker area here that I've circled with a red oval is probably where the bulk of the tumor is. However, you can see that there's a huge area around this where there's a massive amount of water and protein leaking out into the brain, and it's pushing on where the spinal fluid is stored in the ventricles here. The person might not have a whole lot of symptoms if he just had this area where the tumor itself is causing the problem. And you can see here when we add the dye, that's pretty well defines the area. But all of this fluid around here is causing a great increase in the amount of symptoms and in probably headache and confusional states as well. So what can we do about that? Unfortunately, we have some very good drugs for this. Steroids are the mainstay of therapy. Corticosteroids is another word for that. Appetite can improve with reduction in pressure. Headache will improve as well. In some tumors, such as lymphoma, actual cell destruction will occur and can actually be considered part of the therapy when you give steroids. So that large white area is what we want to get rid of. And when you compare where the dye is, you will have far fewer symptoms if we're able to get rid of that large white area from the leaky blood vessels. Now, there's several different kinds of steroids, and I've put the one that is most commonly used at our institution, and I believe at most institutions, in red. That's dexamethasone, and it's a pretty powerful drug. Your own body is going to make something close to something called cortisone, and 20 milligrams of that is equal to about 0.75 milligrams of dexamethasone. So as you can see here, it is the most powerful of the drugs. If I had to guess at what a second drug that many people might be using would be, it would probably be methylprednisolone. Now, why would we choose dexamethasone over methylprednisolone? They're both fairly expensive drugs, and they're more expensive than the readily available prednisone. But let's look at one thing here, the half-life, how long the drug lasts in the blood. Is very long with dexamethasone, and that means you don't have to wake yourself up at midnight and 6 a.m. and take something at noon and then 6 p.m. and then wake yourself up at midnight again. With methylprednisolone, you have to take it several different times a day. Some of you may have had the experience of going home with a very rigid schedule only to come back and see your doctor and have the doctor say, why are you doing that? You don't need to set an alarm. You can take this a couple of times a day. With dexamethasone, you can often take it only once a day. Now, I'll be careful here. There are a couple of drugs, one of which is phenytoin, a very commonly used seizure medicine, that may make it necessary for you to take it more than once or twice a day because it speeds up the destruction of the dexamethasone. So in general, we prefer this drug, and we only give it once or twice a day. We give it first thing in the morning, and we give it in the early afternoon. We don't give it at bedtime. If anybody is listening has experienced jet lag, then you know that your body has a little burst of steroids before you wake up in the morning, and if you take a dose of dexamethasone at bedtime, well, guess what? A couple of hours later, you're going to have a burst of steroids, and you're going to wake up and be unable to sleep. It would be wonderful, and for those of you who are listening who have relatives who are medicinal chemists, tell them that an important patient care development would be to find a good alternative to corticosteroids. We've been using these since the 1960s, when the first doctor who developed this actually took a large dose himself just to see if it was all right. He took 40 milligrams at once. We now know that he did okay, and he introduced this into patient care, making a world of difference for people who are undergoing neurosurgical procedures. But we need better alternatives, because you'll see in a minute the many side effects that come from needing to be on these steroids. VEGF, vascular endothelial growth factor, is a drug, as a series of drugs that reduce this swelling from the leaky blood vessels. And some of you may recognize the word bevacizumab, which was the drug that was introduced about 8 years ago and has taken a very important place in helping people to reduce the need for steroids. We'll come back to that in a little while. This is a kind of daunting slide because this is all the complications of corticosteroids. Importantly, they're not always related to the dose that you're taking. Some people can take really big doses of almost any of these drugs and have virtually no side effects. Others will take just a little bit, the type you might take just if you had poison ivy or something, and have a whole host of side effects. I've made two columns. And in red, I've put some of the very predictable things in the common column. Myopathy, that means trouble with muscles. I'm going to show another slide about this in a moment. But very important to note that people who are taking steroids in bigger doses bigger than maybe 3 or 4 milligrams of that dexamethasone a day will develop weakness in the muscles. It's often painless, and it sneaks up on you so that one day you have trouble getting out of a chair or off a toilet or out of a car, and the next day there's trouble going upstairs, and it seems to come on very quickly, but it's actually been building up. And since many people need to take it for a couple of weeks or a couple of months sometimes, one has to be very careful with that. Almost everyone will have some degree of appetite stimulation, weight gain, and there's a tendency to retain fluid and salt. So some physicians will say, be careful of the amount of salt that you take. Behavioral changes are extremely important. I'm going to come back to that in a moment. Most of us would feel a little non-specifically revved up on steroids, but for some people this becomes an active problem bordering really on cognitive changes and psychosis. So let's keep that in mind. We'll come back to it. We try to take it early in the day, as I mentioned, so that people get some good sleep. Diabetes. We make many people glucose intolerant, so their blood sugars go up. They never had diabetes before, but now they may actually need insulin. So that's a very important side effect. Many people will notice a little bit of tremor and some visual blurring. Some people will complain bitterly that there is, instead of an appetite stimulating effect, there's reduced taste and smell, and thus nothing really tastes very good. A very important thing for your physicians to keep in mind as you go through this is that osteoporosis in people who've been on this for more than a couple of months is accelerated. Taking calcium and vitamin D is very important, but despite that, some people will actually have a compression fracture. And the symptoms of that might mean that they had sudden back pain in a very specific place. And there are some very good procedures in which a substance is injected into the bone that allows the bone to re-expand and gets rid of the pain really very nicely. So hopefully none of you will experience any of that, but it's something to be aware of when you need to be on steroids. In the right-hand column are somewhat less common symptoms. Now, frank psychosis, as I mentioned, is part of the spectrum of behavioral changes, and some people will have hallucinations with this. Hopefully that's not very common. Some people will have very hard to treat hiccups, and frankly, I don't know what causes that, but if you find yourself really sort of uncontrollably hiccuping, take a look at your medication list, and if dexamethasone is on it, it's probably the culprit. Dementia is a scary word, and some people have looked at MRI scans of people who've needed to be on steroids for a long period of time and noticed that certain areas of the brain that are helpful for memory might be a little bit smaller. This is really not common and should not be a reason not to take the right amount of steroid that you need to control the symptoms. Seizures are also very uncommon. It's really more likely that you'll have seizures in tapering off the steroids. So steroids don't cause seizures, but changes in doses might bring them on. The next big words, epidural lipomatosis, means fat that gets deposited outside the spinal cord and can actually sometimes cause pressure on the spinal cord. Again, these are things that happen in people who've been on steroids for a long period of time. I mentioned the vertebral body, the bone collapsing, causing pain. This can happen in the hips as well, and it can happen well after the person has been off the steroids. So people will develop pain in the groin or maybe pain in the hip area going into the upper thigh, and it hurts more when you stand on it. That's something to be aware of. Allergy suppression is a kind of funny thing. You might be very allergic to the seizure medicine that your doctor chooses, but you're also taking Decadron. So you don't know it because Decadron's one of the best allergy medicines out there. And then you go home and taper off the Decadron, and all of a sudden you have a terrible rash. Turns out you were allergic to one of the medicines, but it was just suppressed. The next two words, RPLS and PRESS, are symptoms that really are something a radiologist would diagnose. Sometimes PRESS stands for posterior reversible encephalopathy syndrome. And 20 years ago this year, a radiologist and some medical folks noticed that certain changes on MRI scans started to happen when people were taking a lot of different drugs, when their blood pressure went up, when they had changes in medication. And these can mimic some of the effects of the swelling of the tumor, but will go away when you change the medicines. Gastric irritation, stomach upset, an acid stomach. We always used to put people on antacids whenever they got put on any dose of Decadron or something like it. It turns out not really necessary unless you've previously had bleeding, or unless a bleeding ulcer or something like that, or unless you are really having to take continuously very big doses of dexamethasone or one of the other steroids. If you're on these medicines for a long period of time, there are really a couple of really important infections to worry about. One is shingles or herpes zoster, which is shown here in the chest area. It comes a bunch of boil-like red areas that come out in a line that goes around the thorax. For a week or so beforehand, there can be pain in that area, and you look at that area, you don't see anything, and then after days to a week or so, these sort of rashes come out. They can be treated very effectively, but the worry is that people may have pain even after the rash goes away. So anyone in his 50s or older should think about getting the shingles vaccine, and this is before you get put on any chemotherapy or steroids. Pneumocystis pneumonia is another complication of being on steroids for a long time, and your doctor will ask about cough or any change in breathing. PML is progressive multifocal leukoencephalopathy. It has gotten a lot of press of late because people who've been taking multiple sclerosis medicines have developed this infection that previously was seen only in people with AIDS infections. This is uncommon and usually happens only after people have been on the drug for months and months. Preventing is the best thing, and so if people need to be on steroids for a long period of time, Bactrim, which is a drug that those of you who are sulfa allergic cannot take, or atovaquone as an alternative for sulfa allergic people is a really good one. And then dependence I'll get back to in a second. Let's go back to the behavioral changes. Agitation. Is this person also taking a seizure medicine called levetiracetam? This is a really good drug. It's easy to take and given by mouth or intravenously, takes care of seizures very nicely, but it too can produce agitation. Again, take the drug earlier in the day, and before you change anything, check with your physician to make sure that he or she is on board with that. I mentioned some of the other changes. The muscle weakness happens in 1 to 10 to 1 out of 5 patients. It's usually much more in the legs than in the arms. And it usually occurs after a couple of weeks on the dexamethasone, most people between the 9th and 12th weeks. Breathing is not usually involved, but it can be. So if the person is just getting weaker and weaker go back to the doctor and say, does he really need to be on this medicine? Can we change this dexamethasone so that he's on effectively less? There is a lower risk if you're also taking certain seizure medicines, which we're about to get to. And if you're getting into trouble with this weakness, changing from methylprednisolone to dexamethasone may be the most important thing to do. And the very most important thing you can do is to stay as physically active as possible. Get involved with physical therapy. Stay as active as you feel you really can be. And here's an important one. This is actually the most dangerous complication of steroids, and we call it adrenal insufficiency. Simply defined, AI is when the body still needs steroids because it's been getting them through pills, and the tumor doesn't need them anymore. So the physician has had you taper off your steroids. He's probably done it very slowly, but a few people, maybe 1 in 50, doesn't get his own pituitary and hypothalamic areas of the brain back making his own hormones again. And he is at risk for dropping his blood pressure if he gets an infection or has to have another operation, something like that. The problem is the symptoms are very nonspecific. So there can be just feeling lousy, feeling cold, feeling sleepy, feeling tired, nothing that really clues you in until the doctor looks back and says, wait a minute, we just stopped the steroids. I'm going to check to see whether you're making enough of your own body's steroids now, or maybe I can give you a little bit more, and it's one of the best things that can happen because you're going to feel great within 2 days of starting the steroids up again in a low dose in the morning. One other thing that steroids do, and I don't know if anyone listening has primary CNS lymphoma, glioblastoma, probably the most common adult malignant brain tumor, doesn't do this, but primary central nervous system lymphoma can disappear when the patient is on steroids. So if you had the person on the left come in, the doctor looks at the scan and says, look at this gray stuff, look at this white area here, I need to do something, and he gives steroids, and a week later, it's almost all gone. There's just this little dot here that takes up the dye that suggests there once was a tumor there. That's great, except we don't know what the diagnosis is. We still need a biopsy, and we need to take away the steroids before getting a diagnosis. So we've taken care of the swelling. And most of you who've had an operation will find yourself on seizure medicines as well. I know this because our colleagues in neurosurgery will almost always put people on seizure medicines. Does everybody need to be on a seizure medicine? Well, here are the data. It kind of depends on the location and what kind of tumor the person has. Up to 70% of brain tumors may have a seizure at some time in the course of their illness. Most occur before any treatment has been given. And then once steroids are started, once the operation is over, the risk of seizures actually becomes less. However, about 1/3 of people will have recurring seizures, which we also call epilepsy. Location counts. So tumors that are out on the surface here, this is a person who has melanoma. And there are multiple brain tumor areas here. And when they're out on the surface, they're particularly likely to generate a seizure. If they're deeper down in here, they're much less likely to. People who have low-grade glial tumors like astrocytomas or oligodendrogliomas are the group most likely to have recurring seizures. Glioblastomas and anaplastic astrocytomas are really somewhat less common. Meningiomas, a relatively slow-growing tumor, have a pretty high risk, often because a lot of them are out here on the surface of the brain, whereas lymphoma is low, and metastatic disease that has spread from somewhere like the lung, is less likely to have a seizure problem. Should everybody with a brain tumor take seizure medicines just because he's had an operation? Our national organization, the National Academy of Neurology, says no. That when they looked at large numbers of people taking phenytoin or dilantin, phenobarbital or valproate, which you may know as Depakote, about half of them had low levels, and it didn't really make any difference. The incidence of seizures was the same, and they had a whole host of problems, including cognitive problems, metabolic problems, liver problems, low blood counts, rashes, weakening of the muscles, weight gain, and mood changes. In fact, about 1 in 4 had to change or discontinue these anti-epileptic drugs or AEDs because of one of those problems. Specifically, people with brain tumors can get into some confusional syndromes from some of these medicines. One seizure medicine can produce a little swelling right here that you see in this MRI scan. That could be confused with a tumor. I mentioned behavioral changes on levetiracetam, weight gain on almost all of them, not all, but most, cognitive issues in all of them except lamotrigine, which is a great drug, but takes a long time to load up. Enzyme induction, what does that mean? That means speeding up the metabolism of certain other drugs so that it actually interferes with the effectiveness of many other medicines. Some of them can be heart medicines or blood thinners or chemotherapy agents. Importantly, the drug that is most commonly used as initial therapy in primary brain tumors, temozolomide, is not affected by seizure medicine, so that is not a consideration here. This is what happens when you really did have an allergy and were on dexamethasone. Then the dexamethasone steroid was taken away, and this person was on phenytoin and developed a terrible rash with the skin actually peeling off there. So interactions of anticonvulsants or anti-epileptic drugs, all of the drugs over here will speed up the elimination of many other drugs that some of which I just mentioned. In the right-hand column are the quote-unquote non-enzyme inducing drugs, and that means drugs that aren't going to interact as much with other medicines. The 3 Ls, lacosamide, lamotrigine, and levetiracetam, are all very good choices. Lacosamide and levetiracetam can be given intravenously, and so that's attractive if someone has had an operation or is unable to take oral medicines. Some drugs will actually increase the toxicity of different types of chemotherapy agents by prolonging their time in the blood. So it's a complicated situation, and people have done many meta-analyses. What's a meta-analysis? A meta-analysis is looking at a whole bunch of different studies, adding them all up, and trying to decide whether the net result is that this drug is good for the problem or not. There was a period when people were putting a lot of patients on valproate or Depakote because there were some studies that suggested that it improved survival in glioblastoma patients. The most recent information is that it does not. It's not a bad thing to be on, but there is no justification for the choice of valproate or levetiracetam for any reason other than seizure control. So there really isn't a drug of choice that can be considered part of the chemotherapy regimen. You've had the operation and you go home. In the hospital, maybe you've had those unpleasant boots on, or maybe somebody's been giving you injection in the abdomen of a heparin-like compound, and that's annoying, but it's life-saving in many situations. Brain tumors produce a hypercoagulable state. What does that mean? It means that it's more likely that blood can clot, and when someone has been weak in one leg and is confined to bed or not up very much, he can get a thrombosis in that calf, which by itself is painful, but worse, the blood clot can travel up the leg and into the lungs, and that can be fatal. Cancer-treated venous thromboembolism is better, cancer-related venous thromboembolism is better treated with heparinoids, and those are the things that were injected in the abdomen of you or a relative while you were in the hospital, but probably not continued when you were at home. If someone has a blood clot or has had a clot that goes to the lung, the choice is between these heparinoids that are injected and warfarin. Sometimes that's actually an insurance-based thing. Not all insurance plans will cover enoxaparin and related drugs. There's some physical measures that can be very helpful, those annoying compression stockings and pneumatic boots that inflate, and again, the heparin injections. Some of you who may have a heart rhythm problem like atrial fibrillation have heard about apixaban, dabigatran, rivaroxaban. These are wonderful new oral agents that supplant warfarin for people who have a tendency to have blood clots and maybe strokes, but there is very limited information in the setting of cancer and in particularly in the setting of brain tumors. So probably your doctors are not choosing that. It is very common. There's something called tissue factor in glial tissues. 1 in every 5 or 6 patients may have trouble with this. The risk factors are age. The older the person, the more likely it is. Blood types A and B, A and AB, are a little bit more at risk. This is a person who has a swollen leg on this side. There's a clear difference between the 2 legs. It may or may not be painful. It may cause a fever. Meningiomas, again, slow-growing tumors that are curable with surgery, have a 1 in 20 risk after an operation. So our surgical colleagues are very, very careful about this. They've done some wonderful studies. And you might say, well, if I have a brain tumor, I've just had an operation, somebody gives me a blood thinner, aren't I more likely to have a bleeding episode in the brain? It was a rather small increase, and there was a trend towards less clotting. This study actually had to be ended early, and we do not usually continue prophylaxis, meaning prevention of blood clots outside the hospital. If the person is very different from if the person has actually had a blood clot. If he's had a blood clot, then you definitely need to continue therapy, probably lifelong, because the risk remains. And so this is just an algorithm that shows you what your doctor might be thinking. You worry that there might be a problem. The calf hurts a little bit. A Doppler ultrasound will be done, probably a computerized tomography scan of the chest, and a blood test for something called D-dimer. If the operation has happened within a week, or if it's a very high-risk tumor type, or if there is blood on the scans, then you can't have the blood thinner, and you might get what's called an inferior vena cava filter. If there isn't a reason not to take blood thinners, then you can have all these different options here. And again, we tend to go with the low molecular weight heparinoids like delteparin and enoxaparin. If the person's insurance is able to cover it, it's a very good thing. So let's move on to fatigue and mood changes. And I mentioned at the beginning that these, I believe, are really under-recognized and certainly under-treated. During radiation therapy, people begin to feel more and more tired, and we actually don't really know why. But when someone says, you know, can I go back to work right in the middle of radiation therapy, I always caution him that he may feel better at the beginning of the radiation therapy than he does at the end, and may find that he needs more and more sleep as time goes by. The inhibitors like bevacizumab, the VEGF that I told you, vascular endothelial growth factor inhibitors, inexplicably greatly worsen fatigue, and it may be the most bitter complaint that someone who's taking this otherwise excellent drug may mention. What can you do? Enforce regular sleep habits. Take those corticosteroids early in the day when you also ought to get your exercise in, probably not exercise right before going to bed, because that actually can make it more difficult to sleep. There are some medicines that are available. Methylphenidate, which is really speed. You've probably heard of it for use in children with attention deficit disorder. In adults, it actually has an alerting effect, sort of both cognitive, mental, and to some extent physical. Modafinil, also known as Provigil, and armodafinil are other drugs that are used as well. Before you start adding those things, take a look at your medication list. Be careful of that most sleep medicines can cause cognitive effects. They can interact with the steroids. They can interact with the chemotherapy. Pretty soon the list gets so long and you wake up in the morning feeling kind of hungover. So less is more. Get rid of any sedating medicines first, and then turn to your doctor and say, is there a role for methylphenidate, modafinil, or armodafinil? There have been some trials, and there was a modest benefit in certain areas of fatigue, but they were very modest. And so sometimes it's actually hard to get these covered by insurance, but it may be worth a try if that seems to be a limiting factor. Is it mood, really? One of the symptoms of depression can be just feeling plenty tired, okay? So change the anti-epileptic drug from a drug that might be causing behavioral changes. Maybe have the time to change over to lamotrigine, which seems to be good for mood. There is no reason not to take antidepressants, and I think some people are really kind of afraid of that. Shouldn't be afraid of it. You should be able to take any antidepressant with the exception of one, bupropion, which can increase seizure risk. The direct effects of a tumor are extremely important. Even before the operation, you may have noticed that it's kind of hard to understand everything, and that family members may have noticed that it's tough to understand for the patient to understand all the implications and all the decisions that have to be made right away. Radiation therapy can actually worsen this. Some chemotherapy can worsen this. Some people will get detailed neuropsychologic testing. Everybody needs a helper. Have somebody who can help with the decision making from the very beginning, get enough sleep, treat the depression, make sure that you have a cortisol that's adequate. Maybe your thyroid's down, and check something simple like B12. Some physicians, radiation oncologists mostly, have begun to use this drug, which is an Alzheimer drug for people who are getting treatment with radiation therapy. There are a couple small studies that show slight improvement in delayed recall loss in treated patients. There is only mild benefit of this very well-known Alzheimer medicine as well. It's also known as Aricept. So putting it all together, most people with glioblastoma have been treated with this regimen. They get temozolomide during radiation therapy, and they'll get up to 6 or more cycles on a monthly basis. So what should you be thinking about? What should your doctor be thinking about besides the chemotherapy and the radiation? It's all the symptoms that we've just been talking about. And there are many opportunities for you and your physicians to avoid problems. No pneumocystis pneumonia. Get a PPD test, that's for TB, before it started. Don't take seizure medicines unless seizures occur, and then choose them carefully. Make sure you get a flu, a pneumovax vaccine. Be aware of the symptoms of blood clots and the signs of those. Take the vitamin D supplements. Watch out for bone fractures. Many people will screen for hepatitis before they start their medication. And so importantly, treat mood and fatigue. So now we're going to turn to a couple of outcomes after the active phase of the treatment to finish up here. Right beside us is a specific group of team members that are pretty new to the neurology world. And I'm sorry to say it's taken us a lot longer than in some other fields like the medical oncology world to bring this model. It used to be that people would get disease-directed therapies, and then when they were no longer working, there would be a team that came in for just symptom management, for palliative care, and might help with decisions about end-of-life care. Palliative care at that point was sort of equated with hospice. I want to say as pronounceably as I possibly can, palliative care is not hospice. Palliative care is specific medical care for people with serious illnesses, like the illnesses we've been talking about. So there is a new model, and that is palliative care from the very beginning. Attention to just the sort of symptoms that we've been describing. Increasingly, neurologists are getting specific training in palliative care. We now have a fellowship that emphasizes aspects of neurologic palliative care. And like, what do they do? What do they do that your own doctor doesn't do? They're sensitive to the things that are likely to happen along the way. So for example, constipation, people aren't up a lot. They might be taking some pain medicines, bowel motility agents, a fancy word for helping one have a daily bowel movement. Compounding suppository formulations are available of most anti-epileptic drugs. Our palliative care team members know where to get these. So if the person can't take medicines by mouth, maybe he can get the same dose by rectum, by a suppository. Nausea can be treated. There are very clear guidelines on how to add nausea medicines, and sometimes delicately treating the steroid dose will help very much. And finally, this team is involved in decisions about end-of-life choices, and they're teaching all of us how to talk to people who are in these difficult situations. This next slide is courtesy of a colleague, Dr. Tobias Walbert, who's at the Henry Ford Hospital, and who has been a pioneer in looking at neuro-oncologic palliative care. Here's a chart from one of his writings. The symptoms that we deal with high-grade gliomas are different from general cancer patients in the last few weeks of life. We have this profound fatigue and weight loss and appetite loss in most general cancer patients. There may be more pain, and thankfully there is not that much pain in primary brain tumors, but making up for that are all of these things that make life much more difficult and make it more difficult for the patient to communicate with his loved ones. Drowsiness, poor communication, speech difficulties, focal deficits like weakness on one side, and because of that, poor mobility. Seizures, we hope, are not going to be a big problem. We lean heavily on steroids and on continuing seizure medicines, whether by mouth or by rectum, as long as we possibly can. It's time to talk about that with your doctor if he hasn't. Pause in the work of the visit and say, I want to introduce something else. I'd like to put this on our agenda today. Could we take a moment to talk about what would happen if I get a lot sicker? I want to see the big picture. I want some advice about advanced directives while I can help make those decisions for myself. Advanced directives are sometimes called living wills. If it's getting worse, I want to tell you, doctor, what the thing that is most important to me is, and I want you to help me get there, and I want you to talk to this person, designate someone who's going to help you make medical decisions if you are too sick to make them. Expect emotion. It's going to be hard to talk about those things, and it's going to be very scary, but it's such an important conversation that you really should have it early on in your relationship with your neuro-oncology team. However, therapies are getting better. Our patients are living longer, and every year we see some new things that happen after people have lived a long time from radiation and chemotherapy. This person has a second tumor, a meningioma that grew many years later. This person's going to need a shunt because the ventricles are getting bigger after radiation therapy. This person has episodes that aren't seizures, that come and go, and they're now called the alert syndrome. They shouldn't be treated with seizure medicines. He's going to be okay. They'll finally go away, we hope. This person may have progressive cognitive damage from the radiation therapy. So all of those things we're seeing years out from successful therapy, and you as patients and family members should be aware of those. Here's a checklist. It's kind of a big checklist. In bigger font over here are the things that happen from seizure medicines, from chemotherapy, and from corticosteroids. The osteoporosis we talked about, the PRESS syndrome. The eyes can be affected with cataracts and dry eye. The infections, second tumors, weight gain, diabetes, this sort of thing. And then the problems relating to radiation therapy. Just hold on to this slide and hand it to your doctor and say, are you paying attention to all of these things that happen in a great many of our patients who have lived a very long time after treatment? So treatment's over. Now we need to be vigilant. Hold on to that checklist. How can we minimize the things that any one person experiences? Stay active. Cardiovascular and bone health are incredibly important. Blood pressure should be treated just as it always was. So should cholesterol. Vitamin D should be checked. Exercise helps. Minimize medications except treat anxiety and depression. And above all, please don't be afraid to describe symptoms, even if you don't think they're related. You know, there's a stomach upset. I have a brain tumor. That's probably not related. Well, it might be. There's pain in the groin. I have a brain tumor. Maybe it's one of those fractures. Tell the person that's taking care of you everything that you can think of. Describe your symptoms, physical, cognitive, emotional, and social, and ask for help. Now, I have not covered in this short presentation any investigational studies or clinical trials. I intentionally did not do that because I think that is a role in your particular situation for you to discuss with your team. But here are some resources. Again, our sponsor today, the American Brain Tumor Association's website, a wealth of information, the American Cancer Society, and these are some university-based websites. This is ours at Penn. You'll forgive me if I put it first. oncolink.upenn.edu has resources both for caregivers and patients and for their physicians, with links to the National Cancer Institute and other organizations that sponsor clinical trials. The same is true of Massachusetts General Hospital and Harvard Medical School's site, as well as Johns Hopkins site, and there really are many others. So I've given kind of a quick tour of the things that can happen. We hope that most of them don't, but the best treatment is prevention. Thank you for listening to this presentation. I want to emphasize the second bullet point here. This is really information for you to consider to be an engaged and informed patient and family. It is not meant as specific medical advice to anyone about diagnosis or treatment. We will address some questions in a moment. It's certainly not a substitute for speaking to your own physician who knows you best, and these decisions really need to be made with that person or those people. There are no sponsors for this other than the American Brain Tumor Association. And thank you very much for listening. I look forward to helping with some of your questions. That's the end of my presentation, Mr. Rock.
Thank you so much. Dr. Pruitt will now take questions. If you have a question you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. Dr. Pruitt, a couple people had asked about necrosis, radiation necrosis. Could you speak a little bit about what kind of complications necrosis can cause and how to
Sure. Right. So radiation necrosis can take a couple of forms and is often a differential diagnostic consideration in people who are several months out from treatment. On the MRI scan, it can look like another mass and can cause the same symptoms that the tumor initially did. There are several advanced imaging studies that we utilize to try to decide whether this is really a recurring tumor or whether it's radiation necrosis. Some of the words you may have heard are a PET scan, a positron emission tomographic scan, or MR spectroscopy or perfusion studies. But once all of those studies are done, sometimes a biopsy is actually needed, or sometimes one needs to take out the mass because it's causing just as much trouble as the original tumor. There are some new treatments for this. Bevacizumab, or Avastin, the drug that I mentioned at several points during the presentation, is a drug that's beginning to develop a bit of a track record in the treatment of radiation necrosis. Most likely, your doctors will have put you back on steroids to reduce swelling because this can produce edema as well. And so that would be a first-line treatment. Bevacizumab might be another one. Some people have heard about taking a dive in a hyperbaric chamber, and you may occasionally see that used as well. So the mass form is one form of radiation necrosis, and the other form of radiation necrosis is what I showed you. I can probably switch back to it. Can they still see my screen?
Yes, we can still see it.
Okay, so in this slide, this is a form of radiation injury that isn't a big mass. It's just all of this white change here. And that has the effect of basically multiple little strokes. It causes trouble on both sides of the brain, more on the side where the person's tumor originally was. And the clinical symptom of that would be cognitive changes, particularly short-term memory, attention, concentration, mood problems, and sort of getting things done sort of problems. And so trying to prevent that with memantine, which is one of the drugs I mentioned, is really in its infancy, and trying to treat the mass form with bevacizumab is the subject of several early but pretty encouraging studies. So it's something to ask your team about.
Thank you very much. A couple of people asked about managing seizures, maybe with complementary or alternative medicines. A couple that were referenced were the use of marijuana and omega-3s. Could you maybe speak to some of this in general?
Sure, thank you. So I think that's a really good set of questions, and as you know, it's been much in the news of late. Let me be clear that the use of marijuana, while beginning to be endorsed by several national organizations for the treatment of certain kinds of seizures, has not been specifically looked at for the seizures in people with brain tumors. So there haven't been good controlled studies where one group gets one dose and another gets another gets a placebo or inactive drug. So it hasn't been looked at for the group of concern today. And the one thing I would say, and I say this to my patients, both with tumors and with multiple sclerosis, is that they are cognitively vulnerable. and because of the treatment and because of the other drugs they're on and because of the problem itself. And so what does that mean? That means if you smoke, inhale, whatever, chew, take some form of combustible or other form of marijuana, the altered sensation, the altered cognition that someone who doesn't have all those problems might experience is going to be so much worse than a person with a brain tumor. And one really has to be careful about that. So I think that's kind of a long-winded answer for saying it can be dangerous. And the original sort of looking at cognitive, or rather at seizure control, is for a totally different type of seizures, those that occur on a genetic basis in children. As far as the omega and other alternative vitamin supplements or things, there's nothing wrong with that. All I ask is that I know what else people are doing. So alternative should not mean that there hasn't been a good study, but often that is what it means. It means that somebody says this might work, so let's add it on. I would say that that is far less dangerous or worrisome than having someone smoke marijuana or take it in some fashion. So the answer is not in on marijuana, and as far as I can tell, most of the supplements that people are thinking about and basically just good vitamin usage is fine.
Thank you so much. You had a wonderful slide earlier on in your presentation about the care team and all the various people who are involved in that. Is there a primary person or a primary point of contact that you would recommend people report symptoms or side effects to?
Well, I think, as I said, that person may vary from one time to the next. And there it is. At the beginning, it could be the surgeon and that surgeon's nurse practitioner or nurse. It could be the radiation oncologist during the 6 weeks after the treatment. It's often the medical oncologist or the neurologist/neuro-oncologist who maintains that control position. Long after the treatment, it may be the original neurologist or the primary care physician, but please be clear on that. Even today, I've had that situation where there's 6 doctors and the patient really wasn't clear to whom he should report these things. And so we should identify at each stage, I'm the person that you need to talk to, okay? And don't be afraid to call 2 people. They'll be happy to tell you which one it really should be. You have to be your own advocate and say, I need to get through and figure out who's in charge here.
Great, thank you. And we have time for one last question. Somebody asked if the neurological effects or complications manifest differently in pediatric brain tumors as opposed to adult brain tumors.
Sure, we didn't have time to address that, and I don't see very many children, but I can tell you what is known. First of all, the distribution of tumors is different in children compared to adults. Instead of having tumors in the locations like the frontal lobe or the temporal lobe, some of the examples of which I showed you, more than half of children have tumors in what's called the posterior fossa, or the back lower part of the brain stem and the cerebellum. The types of cells are different as well, medulloblastomas and brainstem astrocytomas. These not only are different types of tumors, but they're in different locations, so you might imagine that they would cause different problems. So a child might be more likely to have obstruction and hydrocephalus and need a shunt. A child might be more likely to have double vision or dizziness. A child might be more likely to have somnolence or sleepiness during the early weeks of radiation therapy than an adult might. We always try to limit the fields of radiation therapy for a child because, as you saw towards the end of the presentation, there really are a host of complications that occur late after radiation therapy. It's one thing if you're 75, but if you're 7, you have a whole lifetime to develop the complications from radiation therapy. So we try to minimize radiation to devise cleverer chemotherapy and more appropriate surgery. So I think the straightforward answer is they're quite different, in part because the cells and the locations are different.
Great, thank you. That is all the time we have for today. Thank you all for joining us, and thanks once again to Dr. Pruitt for her wonderful webinar presentation. To help connect patients and caregivers with information and resources that can help support them in the brain tumor journey, call the ABTA Care Line, which is staffed by caring professionals, at 800-886-2282. Let's pause just for a moment to conclude our webinar recording.